To get off audio and let me share my screen. I thought I'd put a plug in for the other um, talks that are coming up, the other topics that will be covered over these monthly series. I'm really glad to participate in this. I'm new to Iowa. I came to be the department chair for OBGYN at the University of Iowa in July. I spent the last 20 years of my life before that at Yale as a maternal fetal medicine physician and chief quality officer and a chief of obstetrics for the five hospital system of Yale New Haven Health. So I'm excited today to talk to you about venous thromboembolism and just share some uh, historical facts about venous thromboembolism and where we are with the treatment and prevention of thromboembolism. And so I'll just start into it. This is the agenda for today. We're going to talk about some background in physiology. I'm going to use the abbreviation VTE for venous thromboembolism in pregnancy. And I'm going to have a brief discussion about measuring VTE as a metric of good or bad quality care and why it's actually hard to measure. Then set up the standard or the expectation for VTE prevention and review some of the risk assessment strategies and tools and maybe give you some tips and tricks behind those, both addressing high risk patients and normal risk patients. You won't really hear me say low risk very much. I usually say normal risk. There's not really any such thing as a low risk patient when you're talking with pregnancy. So I talk about normal risk. Um, this slide reviews some of the background, and I'll be happy to share any of these slides with anybody who wants to ask for them. Christina can share them, or I'm happy to share them directly. But venous thromboembolism, why we're talking about it today and why it's one of the first topics for this series is because it's a leading cause of maternal mortality in the United States, and it's thought to be a leading preventable cause. These days, it ranks about sixth as leading among the leading causes for maternal mortality. The general frequency of venous thromboembolism has not changed in the past 2 decades. So, despite our efforts, especially over the last decade, we've not really reduced it as a cause of death and the frequency of the cause of death. But it used to be a lot more of a leading cause. It used to be the third leading cause of death overall, and now it's the sixth leading cause. And that's because there are other problems that have um, uh, become higher ranking in terms of causes, particularly substance abuse and mental health disorders. The incidence overall is about 1 in 1,500 pregnancy, and death from VTE is about 10-fold increase compared to a non-pregnant cohort. We think about venous thromboembolism in two periods during pregnancy, antepartum and postpartum. And the most VTEs do occur in the antepartum period, although the risk is higher in the postpartum period. And so let me go through that. The incidence in the antepartum period is about 5 to 12 per 10,000 births. And that's about 7 to 10-fold over controls. And most of those venous thromboembolisms occur more before 20 weeks, and that happens to be one of our cases today. And overall, the majority of VTE events occur in the antepartum period. And that's probably a good thing because that's when we're following people most closely. And when we follow people really closely, we can pick it up and we can prevent the complications of venous thromboembolism. In postpartum, its incidence is reduced, but it's about half of what it is in the antepartum period. But it's a higher risk because the duration of the postpartum period is a shorter duration. And so it makes it look like the frequency is higher in the postpartum period, but that's just because we count the postpartum period as about 6 weeks. Traditionally, we've said that the highest risk is 6 weeks, and that's true, but the risk probably goes all the way out to 12 weeks in the postpartum period. So people really haven't cleared their risk till about 12 weeks postpartum. Now, while I said that the risk of venous thromboembolism is higher in pregnancy, the risk of death is higher in the postpartum period. And that's probably because we don't catch them as much. They're not integrated with care as much in the postpartum period. And this is why postpartum care is so important, and care in the year after birth is so important. So about 25% of maternal deaths due to VTE occur in the antepartum period before somebody's delivered. Then it's about 20% occurring in the first day after delivery. And that's probably a high proportion of cesareans that are done during the period of death, like a perimortem cesarean done. And so that's probably an elevated uh, uh, an elevated number because the venous thromboembolism event, like the PE, precipitated the delivery at that time. And then you can see when you go out 8 to 42 days, it's about 20% during that period as well. And so really those first 6 weeks after birth are where a large majority of deaths occur, over 20% of deaths occur. And that's from national statistics from about 10 years ago. And when we think about what types of venous thromboembolisms we have uh, generally a DVT or a PE, and most frequent is the DVT. That's about threefold higher. And we do also see pelvic vein thrombosis, which is about 11% of our DVTs in pregnancy, and that's very rare in non-pregnant women. And pelvic vein thrombosis is like ovarian vein thrombosis, which can occur because of inflammation and compression of the ovarian vein from the uterus during pregnancy. A majority of DVTs are on the left side. And so that's when we're seeing patients and we're thinking about what side they're presenting with pain, swelling, numbness, or color discolorations in the left side. That should definitely raise our suspicion because 70 to 90% of DVTs are on the left side. And that's generally because of the common iliac artery. The right common iliac artery crosses over the left common iliac vein, and that compression of that artery on the vein becomes worse in pregnancy because of displacement from the uterus. And about 75% of fatal PEs occur after cesarean. And so when we talk about risk stratification, we talk about which patients should get prophylaxis, and we focus a lot on cesarean delivery. That's the reason why, because we're trying to prevent fatal PEs in the population that represents the majority of fatal PEs. This is going back to medical and nursing school. We remember Virchow's triad. That's Rudolf Virchow on the left, and pregnancy is a setup for Virchow's triad. The three pieces that contribute to an increased risk for thromboembolism. We have tissue injury, hypercoagulability, and venous stasis, and all of those happen in pregnancy. The key thing about tissue injury related to pregnancy that a lot of people don't understand, it is related to surgery and having a cesarean, and oftentimes we do see infections in pregnancy, but the real tissue injury that we see that contributes to thromboembolic risk is the tissue factor that's released at placenta separation. So it's actually the physiology of birth. When the placenta separates, it releases something called tissue factor, which is a procoagulant factor, gets released into the maternal blood, and that's a procoagulant factor from that tissue injury. So it's not really abnormal tissue injury, it's the physiologic process, but tissue factor is the main culprit there. Then there's the issue of hypercoagulability. We see changes, and this is on the next slide, in the proteins that are involved in the coagulation cascade. There's a decrease in protein S and an increase in some other procoagulant factors. And we also see an increase in von Willebrand factor. And then we have the issue of venous stasis. There's uterine pressure on those pelvic veins and the veins that go to the legs. And there's also venous dilation from progesterone that happens. And so that venous stasis that happens also contributes to the third part of the triad. These are the changes in the coagulation system that we see. And it's really important to know that we see an increase in a lot of the procoagulant factors, but critically, there's a decrease in free protein S. And protein S is an anticoagulant agent. It's made by the liver, and that's decreased in pregnancy. And sometimes when we're looking for inherited disorders related to thromboembolic risk, and somebody has a PE and perhaps they're pregnant, and we want to do an inherited thrombophilia workup. Some of the tests that we send are genetic tests, but we also send protein factors like protein S to figure out if somebody has a deficiency of their coagulation system that's from a genetic factor. Protein S is one of those things that we don't send in pregnancy. You have to verify that once they're not pregnant 12 weeks afterwards. So this chart's always very helpful. This comes from the ACOG practice bulletin. I asked at the beginning, or I said we would talk a little bit about venous thromboembolism as a quality metric. And this was studied by the Maternal Fetal Medicine Unit Network, which is a network of hospitals and academic centers that do research on pregnancy. It's been around for about 25 years. And they got together towards in about 2010 to figure out what are the major quality factors that we can track across hospitals, and can we measure quality differences among hospitals? And one of the things that they wanted to look at, one of the 5 quality metrics, was venous thromboembolism. And so they took this study and they looked at over 100,000 women and neonates over a 3-year period. And they wanted to see if there were differences in venous thromboembolic rates, and could this help us look at the quality within these hospitals? They calculated their sample size on a risk of VTE after cesarean of about 0.5% and a risk for all deliveries of about 0.2%. But they had about 1/10 of the number of deliveries that they predicted. So what they concluded from this was that, one, MFMU hospitals might have had a very good venous thromboembolism prophylaxis approaches, but this pretty much threw out VTE as a very good quality metric because the incidence is probably a lot lower than what we thought it was before this study happened. So we don't generally measure this across hospitals. We're not measuring this in Iowa to figure out which hospitals are doing a good job and which hospitals are doing a bad job. And this also makes it hard when we talk about the prophylaxis regimens that are recommended by some of our societies. Also makes it very hard to see if we're doing a good job to prevent venous thromboembolism. So it's a bit of a problem where we're going to come up with some recommendations about how to prevent venous thromboembolism, but we actually have no way of measuring the outcomes and figuring out if we're doing a good job because it's such a rare occurrence. So that's just a quandary for us, and it makes us think maybe we should be looking at process measures for how often are we following the recommendations that we suggest, which we will get into in a second. A year after the APEX study, the Council on Patient Safety in Women's Healthcare, which is now converted into the Alliance for Innovation in Maternal Health, recommended this safety bundle in 2015. And like all of the AIM safety bundles, it uses the readiness, recognition, prevention, response, and reporting systems to give recommendations for what hospitals should be doing. And they recommended a standardized risk assessment tool and standardized recommendations for mechanical thromboprophylaxis and for the agents for prophylaxis and therapy. And they asked us to monitor process metrics and outcomes. So you'll see that they focus on monitoring process metrics in addition to outcomes. So we should certainly look at the outcomes and review them, but the focus is probably more looking at process metrics and how often in patients who should receive thromboprophylaxis do they receive thromboprophylaxis. There are 4 main risk assessment tool examples that we have, and these are the ones I'm going to focus on for the next few slides. They come from ACOG, CMQCC, so the California Maternal Quality Collaborative, the American College of Chest Physicians, or ACCP, and then the Royal College of Obstetricians and Gynecologists, which is the equivalent of ACOG in England. The tools um, have a sort of severity element to them or a stratification element to them that make them very different from one another. ACOG focuses their risk assessment tools on people with thrombophilias or personal histories of venous thromboembolism. CMQCC adds on top of that a simple risk assessment, mainly around cesarean delivery and obesity, and I'll be going into detail. And then ACCP and RCOG have much more granular recommendations around their risk assessments, and we'll see examples of those. So first we have ACOG, where they give their recommendations around high-risk patients. And high-risk patients are people who might have a venous thromboembolism or a history of a venous thromboembolism, or they have a thrombophilia or a family history of a thrombophilia. And this is a very busy chart, and we're not asking anybody to memorize it, but it's a really useful tool for when you have a patient who has a history of a venous thromboembolism or has a family history or has a risk factor for thrombophilia or has an inherited thrombophilia. And you can go through it, and the one that always comes up that I like to sort of focus on with this is a patient who has let me find it here. Where did it go? Patient with a family history of a thrombophilia does not get any special thromboprophylaxis. But then you have a patient with a low risk thrombophilia, like a heterozygote of factor V Leiden or a heterozygote of the prothrombin gene with a family history of VTE. And generally, the recommendation for somebody like that, who's one of the more common people that we would be looking at this table for, that patient would probably just get postpartum prophylactic anticoagulation. But this tool is very useful to have. It comes from ACOG Practice Bulletin 196. So this is the ACOG recommendation around high-risk patients. But what do we do, or what should we do around normal risk patients? And this is what we see every day, patients who come in and deliver by vaginal delivery or by cesarean delivery. So this goes back to those 4 different classification groups, the ACOG recommendations, the CMQCC recommendations, the ACCP recommendations, and the Royal College recommendations. And so going through them again in terms of how they approach their recommendations, ACOG just has those high-risk people, and that would cover about 1% of patients. So that provides the recommendations and a thromboprophylaxis regimen around 1% of our patients. Then if we use the CMQCC criteria, which uses a major and a minor risk assessment, which we get into in a couple of slides, those are related mostly to obesity and cesarean delivery. We would be covering about 25% of our patients with thromboprophylaxis, like Lovenox postpartum. If we were to use the CHEST guidelines and the RCOG guidelines, those go up to 35% and 85%. So the RCOG guideline actually ends up thromboprophylaxing a large percentage of the population giving birth. And a lot of people recommend or comment on it, that's probably too many patients in the long run. It's a complex scoring system and an extensive risk factor list. This is actually the RCOG recommendation around prophylaxis. And I look at this and my head just spins because it's so complicated and you got to know what all these things are. Unless you had it built into your electronic health record and you had almost an AI analysis of the medical record and it spat out what orders you should order for your patient postpartum, this is a really confusing guideline. And it's generally discouraged against because it's so confusing. You're bound to get it wrong in implementation. And as I said before, it would thromboprophylax about 85% of the population. So most people go to more simple recommendations. And this is the CMQCC recommendation around thromboprophylaxis around patients with cesarean birth and whether or not they have major risk factors or minor risk factors. And the major risk factors are related primarily to BMI or obesity, postpartum hemorrhage with transfusion, and infection, prolonged hospitalization, and then some specific chronic medical conditions. And those are really easy to keep track of or even build into your electronic health record. And then they have these minor risk factors, which include smoking and preeclampsia. Patients with one major or two minor risk factors who also have a cesarean would get in-hospital pharmacologic prophylaxis. So something like Lovenox for the 3 to 4 days that they're in the hospital. And then that would be discontinued after discharge. So again, another way to look at it is a patient with a cesarean birth, their risk assessment. And this is really easy to build into the electronic health record or even the postpartum order set. You can check off whether or not people have the major or minor risk factors, and that can steer you into ordering the right thing when you are writing the orders for their postpartum period. And again, so just to take an example of a patient who has one major risk factor, so that might be BMI of 40 and a cesarean delivery, those patients would get mechanical prophylaxis placed prior to the cesarean. It continued until they're ambulatory the next day. And you would be giving low molecular weight a prophylactic dose, so a once a day weight-based dose. These are the anticoagulation regimens that we typically use. When we talk about prophylactic low molecular weight heparin, it's generally enoxaparin 40 milligrams or Lovenox 40 milligrams once a day. And we do that from after delivery until the time of discharge. And then these intermediate dose and adjusted doses are patients with thromboembolic histories or with high-risk thrombophilias. And then we also have the recommendations around what to do for if we are using unfractionated heparin, so standard heparin, and what those doses would look like for unfractionated heparin, which is a trimester dosing, different scales for the different trimesters. And I'm sorry, my mouse is so sensitive; it keeps going from slide to slide. And then how long postpartum anticoagulation lasts in patients with high risk or intermediate risk thrombophilias and risk for venous thromboembolism. That generally lasts about 6 to 8 weeks. So those aren't your typical cesarean, obese. Those are patients with thrombophilias, for instance, where you would give 6 to 8 weeks. There are also recommendations around the timing of neuraxial anesthesia after you stop or withhold a dose of thromboprophylaxis. And that's also in the ACOG practice bulletin. And this is a really helpful table to work with your anesthesiologist. And they generally have this memorized, an anesthesiologist, in terms of when they can place the epidural after you've dosed a low molecular weight heparin. So sometimes we will adjust people when they get closer to term. We'll convert them from low molecular weight heparin to unfractionated heparin so that they can receive their epidural if they came in labor, because you have to hold low molecular weight heparin for a longer time before giving it before giving an epidural. But the practice now is typically to just continue low molecular weight heparin all the way through the third trimester and to thread the needle when somebody comes in labor, and not to convert them to unfractionated heparin, or even to stop the low molecular weight heparin and time their induction around anticoagulation. So now we have time for some case presentations, and I think we have a case presentation from the last session that we're going to go through first, and then we'll do